Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm pleased to bring to you another great interview. Today's guest is Giacomo Asquini. Giacomo is the head of craniomandibular physiotherapy services at the Italian Stomatologic Institute in Milan, Italy. He specializes in the management of patients with temporomandibular disorders, and he is currently working towards a PhD at Birmingham University, which is located in Birmingham, England, on the role of physiotherapy in TMD, and he is doing so under the supervision of Professor Deborah Falla. Additionally, he collaborates in teaching TMJ evaluation and treatment at the University La Sapienza in Rome, Italy. We invited Giacomo to the podcast today because he was recently the primary author of an article published in the Journal of Oral Rehabilitation titled Effectiveness of Manual Therapy Applied to Craniomandibular Structures in Temporomandibular Disorders, a Systematic Review. I hope you're as excited to learn about the results of the study as I am. My exuberance aside, though, let's prevent any further delays and get to the interview. Giacomo, welcome to the podcast. How are you today?
I'm fine. I'm from Italy. It's a beautiful night.
Well, that sounds amazing. It is also a beautiful evening here, not quite night. And let's just jump right in. We can start off by asking you to talk to us about what made you interested in this particular topic and why you thought doing research on this topic would be helpful for the profession.
Well, I started getting interest in TMD 10 years ago, a few years after my undergraduate studies. Initially, I decided to approach this area to differentiate my clinical practice from classical musculoskeletal rehabilitation on the neck, back, or shoulder, for example. I thought to develop a clinical niche dealing with something uncommon among physiotherapists and have also fewer competitors in the private sector. And this was my initial plan, and I decided to try with TMDs just out of curiosity. After a few years, this clinical niche, at the beginning, it took only 3 hours per week. And so this clinical niche, after a few years, has become my full-time job. And today, I see only TMD patients, and I have treated more than 2,000 patients with TMD in the last 10 years. And so, about 6 years ago, I decided to invest only in this area. We can say I decided to do an all-in this area. And so I proposed to Prof. Deborah Falla to start a PhD on the role of physiotherapists in the management of TMD. Now, you asked me why it would be helpful for the profession. Well, the most significant thing to keep in mind is that TMDs are musculoskeletal disorders, and therefore physiotherapists should not fear treating these patients. The clinical approach is the same as for neck pain or shoulder pain. And so, clinical reasoning, education and information, manual therapy, and exercise. Moreover, there are other reasons why this area will grow for physiotherapists in the coming years. First, research over the past 10 years underlined and enhanced the role of physiotherapy in TMDs. Then research in dental field is moving towards orofacial pain. That means also neuropathic or odontogenic facial pain, for example, and not only musculoskeletal facial pain. And this will leave more room for physical therapists to manage musculoskeletal facial pain, that is TMD. And finally, some dentists, for reasons related to professional attitude and profitability, prefer not to deal with neatology, but instead with orthodontics or oral surgery. And for all these reasons, I believe that in coming years, the role of physiotherapists in TMDs will be increasingly recognized and appreciated.
Excellent. Thank you for that answer. And I love the answer. In particular, I think we need more people like you in our profession diving into this topic because it is an underappreciated area. In fact, in your response, you used a couple of words that always make me a little sad. And that is when we talk about temporomandibular disorders, we have to use words like uncommon and niche, when in fact, as you're well aware, these disorders are extremely common, and patients around the world need our profession to be as focused on temporomandibular disorders as we are things like neck pain, hip pain, and knee pain. But unfortunately, to this point in time, that's just not true.
I completely agree. And with my work, I try to do my part.
Well, thank you for doing your part. And moving forward, getting back to the systematic review that we're here to talk about today, what were the inclusion and exclusion criteria for this particular review? And perhaps specifically, in addition to that, how was manual therapy defined during the investigation?
Thank you for this question because it allows me to explain where this systematic review comes from. Previous work investigating manual therapy in TMD have been very helpful and useful to show the effectiveness of manual therapy in managing TMD. This was the knowledge. So, is manual therapy useful for TMDs? And the answer is yes. Nevertheless, these previous studies examined manual therapy in general, including studies with different manual techniques applied to different body areas. Although manual therapy generally includes different approaches in different body regions, the effectiveness of techniques targeted on specific regions is essential information for manual therapists planning TMD treatment. I therefore proposed to Prof. Deborah Falla to do this review to answer a very simple clinical question. If a patient with TMD comes to me as a manual therapist, does it make sense to put my hands into the mouth, or is it better to treat something else? And to address this point, we set very restrictive inclusion criteria for the type of intervention. First, manual therapy only, defined with definition from the American Academy of Orthopedic Manual Physical Therapy, is taken from the description of Advanced Specialty Practice 2008, and so any hands-on treatment provided by the physical therapist. So we excluded manual therapy intervention combined with other therapies like exercise or oral appliance, for example. And then we restricted, again, the manual therapy intervention only to the craniomandibular structure for a reason I explained before. Other inclusion criteria were for study design only RCT with comparison groups not including a manual therapy intervention. For population, we choose adults with signs and symptoms of TMD or with a TMD diagnosis according to the diagnostic criteria for TMD. As outcome measures, we set TMJ opening, range of motion, and pain, since TMD are principally characterized by jaw pain and jaw movement limitations.
Thank you for that information. Your description is not only really clear, but I think it's very helpful when people are attempting to understand the clinical significance of the work that you've just completed. And in terms of moving forward, when you actually performed the search that you were just describing some of the parameters for, how many studies were identified, and then how many studies were ultimately included in this systematic review? And, for those familiar with the terminology, another way of me asking that question is, can you describe in brief what your Prisma flow sheet looked like?
Great. We tried to be as inclusive as possible in the search phase by querying more than 10 databases. And these led to the identification of nearly 5,000 papers. Yes, 5,000, a lot. Which, after removing the duplicates, had become just over 2,700. Maybe a lot again. Anyway, we screened these papers and identified only 15 papers as potential included. And among the major reasons for exclusion, I would like to underline that about 860 papers were excluded because although investigating a manual therapy intervention in patients with TMD, they combined this intervention with other therapies. The most common ones were exercise and oral appliance. And again, in the full text phase, for the same reason, we excluded 4 papers more. And so, in the end, only 6 papers were included.
To me, it's just simply fascinating that, after getting rid of the duplicates, etc., you went from over 2,000 papers down to just 6 that focused based on your inclusion criteria on manual therapy. It, of course, conveys to me the message that we don't have enough research yet on this topic, but the number 6 isn't necessarily bad if you have well-done studies. So, as we move forward here, the next logical question has to do with what were the characteristics of these studies that you included in the process. For those that are interested in the paper, we, as always, link to it in the show notes where they can find this content in Table 2. I know this particular table has a lot of potential content that you can't completely go through here, but please speak to us briefly about the basics of these 6 studies and what you saw in them when you were able to read and review the content.
It's not easy to sum it all up, but I try to do my best. Well, half of the included papers are from Australia, 2 from Brazil, and 1 from Poland. Except for an older article, the other ones were made between 2012 and 2018. 5 papers used the research diagnostic criteria for TMD as a diagnostic criterion for the inclusion of participants. And in my opinion, this is a very reasonable choice. In particular, 4 papers included only myogenic TMDs, while the other 2 included mixed forms of TMD. Concerning the intervention, in most papers, the manual therapy sessions were spread over 4 to 6 weeks, with an average duration between 20 and 30 minutes for each session. The manual therapy techniques included in these papers were mainly on masticatory muscles, with both an extraoral and intraoral approach, and then also mobilization of the TMJ. Manual therapy targeted on craniomandibular structure were compared with very different therapies in those papers. For example, with education, no treatment, oral appliance, or kinesiotape. And this fact generated a lot of heterogeneity in our review, and unfortunately, did not allow us to complete the review with a meta-analysis because of heterogeneity.
Well, thank you for that brief description. As you said, there's a lot of content and it's hard to do, but I think you did a wonderful job. And as is always the case, in addition to understanding these basic parameters of the studies, it's of course also important to be aware of the risk of bias of the studies that were included. I know from reading your paper, of course, that per accepted standards, you did in fact evaluate the risk of bias of each of these studies. When you did that, what did you learn about this available evidence that's included in your review?
Well, when dealing with an RCT investigating manual therapy, it is challenging to leave participants blinded to the type of intervention. So I expected an increase in the risk of bias compared to other fields of medical research. But what surprised me, however, is that no included papers published the protocol before starting the recruitment of participants. And this is a serious fact because it impairs the transparency of the research. Publishing the protocol before carrying out the study is really a guarantee of transparency and also allows potential external evaluators to assess the research better. Anyway, in this field, as in other fields of physiotherapy research, there are still many steps to be taken to consolidate the current evidence.
Well, unfortunately, I have to say I'm not surprised that there weren't enough prospective registrations. That's a problem I've witnessed before in our profession, and hopefully we improve upon that in the future. That having been said, related to your study, the next logical question, and perhaps the most important question for listeners, what were the results of this paper, and what do you think clinicians should know about these results as it relates to the utilization of manual therapy on patients with a TMD problem?
Starting from the research question we asked at the beginning, that is, does it make sense to put my hands into the mouth, or is it better to treat something else? The answer from this review is yes, it makes sense. In fact, all included papers found an improvement in pain and or TMJ range of motion following manual therapy. But what remains unclear is the superiority of manual therapy in comparison to other types of intervention. So the message that clinicians should take home is that manual therapy applied to craniomandibular structures is a useful therapeutic weapon to be used on a pair with other therapies. The challenge for the clinician is to understand when to use it and on which patients. Here, I link to another publication we did this summer on musculoskeletal science and practice, which we can say completes this review. We identified some predictors of good outcomes following manual therapy applied to craniomandibular structures. In particular, we found that patients with the following features obtain a significant pain reduction following manual therapy. 1. Patient reporting pain intensity greater than 2 out of 10 during mouth opening, and so mechanical pain. 2. Patient experiencing positive expectations of outcome following manual therapy. 3. Patient with pain localized in the craniocervical region. And last, patient with low central sensitization inventory score. And we found that patients with these features obtain a significant and clinically significant reduction in pain following manual therapy. And this new knowledge helps us to select among TMD patients the suitable patients who best respond to TMD. In conclusion, the findings from this review are helpful, but must be integrated with other evidence, for example, that on predictors, in order to offer our patients the best therapies.
I really like the practicality of the way you broke down that overview of the results. It seems like a useful approach from very specifically a clinical reasoning perspective. And in your answer, you've already partially or maybe sufficiently addressed what my next question was going to be. And that is, as is always the case when we do a systematic review on a question like this, there are flaws in the available evidence, and we always, to a certain extent, want to see more and better research. Because of that, what are your opinions on taking manual therapy evidence from other areas of orthopedics and then applying them to this area until we have better evidence related to the temporomandibular joint?
This is a complex question. Firstly, I would like to specify that I deal with manual therapy in TMDs and not with manual therapy in general. Moreover, I didn't treat patients with other musculoskeletal disorders outside of TMD during last 6, maybe 8 years. I'm not well informed on latest evidence. However, I believe that in clinical activity, but also in research, we should seek precision rehabilitation, that is, offer our patient a tailor-made treatment planned according to their clinical and personal characteristics. In this context, clinical reasoning is critical, but also knowing patients' attitude and beliefs, and if possible, having clinical tools to better identify responders and non-responders to different therapies. I really love performing manual therapy with my patient, and I think that the level of evidence supporting the role of manual therapy as pain modulator is good, but I don't believe that all patients should be treated with manual therapy. Being physio in this way is more complex, not always possible, but I think it is absolutely more captivating for us and more right for our patients.
I think that's a great answer. And while I'm clearly biased on this topic, I use manual therapy every day on patients that have temporomandibular disorders, and I find that it works really well. I look forward to the day when our published research catches up with what some of us see in the clinic from a professional perspective. That having been said, I'm not sure we'll ever have, of course, perfect evidence. And moving forward, I really like how you point out that we have to do things like see if the patient responds well to manual therapy. Patient A and patient B might not respond in the same way. So then we think through the process, and with some evidence to inform us, we make individualized decisions that are specific to that particular scenario in the clinic. And really, that's no different than what we should be doing for all of our patients of all different diagnostic categories.
I completely agree with you, and in TMDs is the same as for other musculoskeletal disorders. Another thing I would like to discuss with you is that during the therapies, we should measure outcomes. And so, if I have a patient with a limitation in TMJ opening, I have to measure it before the treatment and before the session at the last of the manual therapy session. In this way, we can understand if our treatment is the best treatment of the patients. And I think that one possible mistake, common mistake by physiotherapists, is to perform a treatment and then see if in the future something will be better without a measure. And so the idea to apply clinical reasoning not only in the first assessment, but in every session of manual therapy will be a guide for us to understand if this is the right patient for manual therapy or not.
That is an excellent addition. Thank you very much for that. And it sounds like we're approaching patient care in very similar ways, which always makes me happy because, this type of thing that occurs around the globe, in this case, of course, physiotherapy, really shouldn't be that different place to place to place. We're all physiotherapists. We're all working on people with the same diagnoses. So it's really good to hear that even across such a far distance, we're functioning in similar clinical ways. And that point having been said, Giacomo, it has been wonderful having you on the podcast today. Not only has this topic been super interesting to me, but I hope our audience also found it to be informative and inspiring. And perhaps most importantly, I know you're still busy working in this area. So hopefully in the future, we see more work and more content from you, and perhaps we can have you back on the show.
Thank you very much for your show. I think it's really useful for our profession, and I will be happy to come again.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.